Recording stopped.
Which was diagnosed 7 years prior to his assessment at the HCM clinic. He also had prostate cancer that was previously treated, as well as a DVT that was treated with anticoagulation. He came into the attention of cardiology after admission to hospital in 2019 for symptoms suggestive of unstable angina. He eventually underwent a coronary angiogram that showed normal coronaries, but his ventriculogram showed a spade-like LV, which is again somewhat suggestive of apical variant hypertrophic cardiomyopathy. And this was corroborated by his cardiac imaging in the form of echo and MRI, which I'll show you a few of those images. His ECG at the time of our clinic assessment, the marked abnormality are these prominent T-wave inversions in the anterolateral leads. And when we see this, this often, again, provides a hint of possible apical HCM. His echocardiogram, this is just one image, the parasternal long axis image, shows normal biventricular systolic function, and there's a hint of increased LV wall thickness in a concentric pattern. When we look at the apical views from the echocardiogram, we see diffusely increased LV wall thickness and tapering at the LV apex, a lack of tapering at the LV apex, which is again suggestive of apical hypertrophy and the apical variant of hypertrophic cardiomyopathy. Whenever we see this, we often assume that this patient has apical HCM. The MRI that was performed earlier that year was reported and interpreted as showing concentric hypertrophic cardiomyopathy measuring up to 16 millimeters, specifically in the anteroseptal segment, with focal mesomyocardial LGE, late gadolinium enhancement, involving the basal infralateral segment, as well as circumferential apical involvement as well. And we'll see that in the later slides that these are segments that can be involved in Fabry disease. So in terms of what we did for him in our clinic, again, our presumptive diagnosis was apical HCM. And just like for many of our HCM patients, our management included coordination of genetic testing. This was primarily not for diagnosis, but to facilitate family screening. Paroxysmal atrial fibrillation was managed as usual with anticoagulation for stroke prophylaxis, as well as bisoprolol and beta blocker for rate control. There were no convincing risk factors for sudden cardiac death to warrant an ICD. There were no issues with intracavitary obstruction and no issues with clinical heart failure. Interestingly, his genetic testing did come back showing a pathogenic variant in the GLA gene, which is diagnostic for Fabry disease. And prior to follow-up of these genetic testing results, he actually developed high-grade AV block, requiring admission to hospital and permanent pacemaker implantation, which, as we'll see, is actually a feature that is more common in Fabry cardiomyopathy compared to HCM. And we subsequently sent a referral to our local adult metabolic disease clinic, who manages these patients with Fabry disease. Why I chose this case, I found it particularly interesting, again, because it has some features to suggest maybe an alternative diagnosis than HCM. The MRI that was performed a few years prior when he came into the presentation and attention of cardiology showed, again, an apical HCM type phenotype. But he actually had echocardiograms even further back in 2016 and 2017 for indications of shortness of breath and LVH on ECG pattern that demonstrated moderate concentric pattern left ventricular hypertrophy with LV wall thickness up to 15 millimeters. Again, a possible clue that there could be something else going on. And on the echo from 2017, there was also a mention of apical hypertrophy, which again suggests an underlying cardiomyopathy. Looking even further back, this was a perioperative ECG from 2010, And already we could see some abnormalities, again, the T-wave inversions in the anterolateral leads. So as far as more than 10 years prior to his diagnosis, we could already see the development of early manifestations of a cardiomyopathy. So the key points for this case, that the reason why I brought this up was I think it really illustrates some of the challenges in diagnosis of Fabry disease, at least from the cardiac perspective. The pattern of left ventricular hypertrophy oftentimes is concentric, and again can be confused with the more common causes like hypertensive heart disease. Whenever we see an apical pattern of hypertrophy, we often think immediately of apical variant HCM rather than Fabry disease. And as we saw on our example, there were differences in interpretation in both the serial echo and serial MRI. In this case, we also saw several opportunities for further workup and diagnosis in terms of evidence of abnormalities on ECG 12 years prior to formal diagnosis. And the patient also had echocardiograms 5 to 6 years prior to diagnosis as well. Those represent opportunities for early diagnosis of Fabry disease. This case also highlighted some characteristic clinical features that can be seen more often in Fabry disease compared to HCM. There was evidence of LVH on ECG and cardiac imaging. There's paroxysmal atrial fibrillation. MRI showed basal inferolateral LGE. And this, again, is a segment that's often involved in patients with Fabry disease. And again, there was advanced AV block requiring permanent pacemaker implantation, which again is seen more often in Fabry compared to HCM. So just a brief overview of what Fabry disease is. It's a condition that involves a mutation in the GLA gene. This results in deficiency of the lysosomal enzyme alpha-galactosidase A, and this leads to accumulation of glycosphingolipids within the cells of various tissues and organs that eventually leads to a multi-system signs and symptoms. The inheritance pattern of Fabry disease is X-linked, and this is in contrast to hypertrophic cardiomyopathy, which is autosomal dominant. In terms of actual clinical expression of Fabry disease, it's considered a rare condition. Prior literature suggests that 1 in 117,000 individuals have this worldwide. But of course, due to founder effects, this can be up to 1 in 17,000 in some communities. In some locations around the world, they actually do newborn screening. And a pathogenic variant is actually seen in up to 1 in 1,300 newborns, but of course, the majority of these do not have clinical expression of the condition. And this is in contrast to the prevalence of HCM, which is estimated to be in the order of 1 in 500. Again, we mentioned that the Fabry disease is a multi-system disease with multiple clinical manifestations involving different organ systems. And the image on the right is the characteristic dermatologic lesion, these angiokeratomas that can occur in classic early onset Fabry patients. The phenotypic expression of Fabry disease can be grouped up into 2 types. Despite the X-linked inheritance pattern, both males and females can be affected. Of course, females are less affected because of residual enzyme activity. The type 1 classical or early onset type is characterized by minimal to no alpha-galactosidase A activity. And this leads to early onset of microvascular sequelae in the form of acroparesthesias, which are these pain and tingling sensations in the distal extremities. The dermatologic lesions that we demonstrated earlier, these angiokeratomas, hypohidrosis, so abnormalities in sweating, nonspecific GI symptoms, and corneal abnormalities. Eventually, these patients develop significant macrovascular complications in the form of cardiac, renal, and cerebrovascular disease. And these patients can have a mean age of death in the order of their 40s. Type 2 or late onset disease is characterized by residual but reduced enzyme activity. And these patients largely have no significant microvascular sequelae, but they can develop the same macrovascular sequelae, although they can happen at later age in their 4th to 7th decade of life. The reason why it's important to identify Fabry disease is because it really, prior literature has shown reduced life expectancy in these patients. And this table just demonstrates that cardiovascular complications represent the leading cause of morbidity and mortality in both male and female patients with Fabry disease. As we saw on our case that we demonstrated, the diagnosis of Fabry disease is often delayed. In this one prior study, the time between onset of manifestations of Fabry disease and diagnosis was in the order of at least 10 to 15 years. Increased LV wall thickness, or what we label as LV hypertrophy, is the most common cardiac manifestation of Fabry disease. And I just want to demonstrate here that the LV hypertrophy phenotypes can be remarkably similar to hypertrophic cardiomyopathy. The concentric pattern is the most common phenotype, where there's symmetric increased wall thickness in both the septal and posterior walls. But we can see the typical asymmetric septal hypertrophy phenotype that we see often in HCM. And this we often mistaken the diagnosis for HCM. The asymmetry is thought to be contributed by the fibrosis that seems to be preferentially involving the infralateral walls, creating this asymmetric appearance. Increasingly recognized is this apical hypertrophy variant that is not only seen in HCM, but can also be seen relatively commonly in patients with Fabry disease. And we also see these rare cases of LV apical aneurysms that develop and are likely associated with this phenotype. This is a nice MRI-based study that aimed to describe the distribution of phenotypes in patients with Fabry disease who have increased LV wall thickness. The majority, again, have this concentric type, but of the non-concentric LVH phenotypes, just over half of them have this asymmetric septal variant, and the other less than half demonstrate apical variant. Like HCM, systolic anterior motion of the mitral valve and LVOT obstruction can also be seen in patients with Fabry disease, but probably less frequently. And these are just some echo images showing the systolic anterior motion of the mitral valve, flow acceleration through the LVOT suggestive of obstruction, SAM-mediated mitral regurgitation, and this classic dagger shape Doppler profile that suggests a high LVOT gradient. There are other potential phenotypes that are much rarer, but have been described in some rare case reports, including LV non-compaction phenotype. And again, increasingly recognized are the development of LV apical aneurysms that again can be associated with the apical variant. In addition to increased LV wall thickness, patients also have increased RV wall thickness in the majority of patients with Fabry cardiomyopathy, and that can be another additional clue to an underlying cardiomyopathy. Biventricular systolic function is often preserved, but with progressive disease, patients can develop diastolic abnormalities. They can also develop subclinical systolic dysfunction despite a preserved EF. They can have abnormal longitudinal strain. And with progressive later stage disease, they can develop overt reduction in left ventricular ejection fraction in a burnt out phase similar to HCM. There was this binary sign that was previously proposed as a potential useful marker to signal possible Fabry disease on echocardiogram, but is now thought to be relatively unreliable due to poor sensitivity and specificity. The proposed histologic cause of this binary appearance is glycosphingolipid compartmentalization, where most of the lipids are seen in the subendocardial layer, whereas the middle layer is preserved. But as we can see from these three examples, a patient with Fabry cardiomyopathy with this binary sign, which is this echo bright stripe in the endocardium. This is an example of a patient with Fabry disease with the binary sign, but below is a patient with Fabry cardiomyopathy without the binary sign. And in the bottom right is a patient with hypertrophic cardiomyopathy with this binary appearance. Papillary muscles are often thought to be more prominent generally in patients with Fabry disease compared to other conditions with increased wall thickness. That could be a clue as well. Biatrial enlargement is very common. Left atrial dysfunction can be detected with left atrial strain imaging and is thought to be a result of at least a couple of mechanisms. One, could be related to chronically elevated left atrial pressures due to increased LV wall thickness and diastolic dysfunction that results from that. There could also be inherent atrial myopathy related to lipid accumulation within the atria themselves. Valve thickening and redundancy is a common finding on echocardiogram in these patients, but rarely does valve regurgitation progress to a severe enough level to warrant valve intervention. These patients also have dilated aortas, but again, catastrophic complications associated with the dilatation is not usually associated with Fabry disease and has not yet been reported. Longitudinal strain imaging is a more novel advanced echo technique that we're more commonly using to detect subclinical LV dysfunction. And in patients with Fabry disease, longitudinal strain can be reduced in any segment. There is, as we had previously mentioned, a possible predilection for the basal and mid-inferolateral wall. The exact cause for this preference is not clear, but again, is a pattern that we are frequently seeing. The more abnormal the GLS, the global longitudinal strain, the more it's associated with late gadolinium enhancement, and which represents scar and fibrosis on MRI. And prior studies have shown that picking up abnormal inferolateral longitudinal strain on echo can accurately predict the presence of LGE in that same segment on MRI. An additional way that strain imaging can be important is to help differentiate between possible cardiomyopathies related to increased LV wall thickness. So patients with the classic septal hypertrophy HCM will have strain abnormalities localized in the areas of increased wall thickness in the septum. Patients with the classic apical variant HCM will have strain abnormalities localized to the apex. Patients with Fabry disease are thought to have these strain abnormalities, as mentioned in the inferolateral wall. And those with amyloidosis have this relative apical sparing pattern. That predilection towards the inferolateral wall has also been corroborated by MRI studies that have shown LGE and the formation of fibrosis and scarring in that specific segment. And increasingly recognized again is the involvement in the apex, again, likely related to that apical variant. MRI has been additionally helpful with the introduction of T1 mapping. And this was a nice Canadian study from Alberta, one of the earlier studies that demonstrated the utility of T1 mapping, which has the benefit of being a non-contrast technique to differentiate Fabry disease from other causes of LVH. And as shown, the baseline T1 values are consistently reduced in patients with Fabry disease, both male and female patients, compared to other control groups with LVH for other reasons. After having the suspicion of Fabry disease, the gold standard methods for diagnosis includes an alpha-galactosidase A level in male patients. This cannot really be used for female patients due to residual enzyme activity. And confirmation can be performed for both male and female patients with genetic testing, identifying a pathogenic variant in the GLA gene. Once Fabry disease is identified and diagnosed, management can take the form of disease-specific therapy as well as just management of the cardiac complications of Fabry disease. Disease-specific therapy includes enzyme replacement therapy, for which there are 2 approved IV infusion options, and chaperone therapy, which stabilizes abnormal enzymes and improves enzyme activity, which has the added advantage of being an oral formulation, but is limited to eligible patients with specific genetic variants. It's important to note that enzyme replacement therapy has been shown to improve some manifestations of Fabry disease, but not others. A prior comprehensive review showed improvement in pain-related quality of life. There are also non-randomized studies that have shown delay in progression of LVH in these patients, but unfortunately, probably unlikely to reverse any scar that has already occurred in the myocardium. And the long-term impact on mortality remains uncertain. And again, just highlights the challenge in these rare conditions to perform randomized trials to demonstrate clear benefit from that perspective. Because of the high potential cost of enzyme replacement therapy, there are specific indications, including cardiac indications, for initiating therapy in patients with Fabry disease. And this is a list that was taken from prior Canadian guidelines. And as you can see from this list, a lot of them relate to cardiac imaging findings, and there are also some associated ECG and cardiac biomarker findings as well that could represent criteria for initiation of therapy. In terms of cardiac complications of Fabry disease, I've grouped them up into kind of 5 main groups and tried to highlight some of the differences compared to the hypertrophic cardiomyopathy population. Several patients with Fabry disease eventually develop atrial fibrillation as part of their natural history. They develop high-grade AV block, potentially, and this is probably more frequent than the HCM population. They have the potential to develop LVOT obstruction, but probably less commonly than HCM patients. Also ventricular arrhythmias and eventually heart failure. Or for management of atrial fibrillation, it's very similar to patients without Fabry disease with some important considerations. Oral anticoagulation with novel oral anticoagulants are still preferred. Rate control can be potentially limited by AV block in patients without pacemakers. Rhythm control could be a preferred option if symptoms are related to the loss of atrial contraction. And it's important to note that there should be cautious use of long-term use of amiodarone because amiodarone can negatively impact phospholipid metabolism and worsen the underlying Fabry disease. Again, some of these patients with high-grade AV block ultimately require permanent pacemaker implantation. LVOT obstruction is managed very similarly to HCM with respect to AV nodal blockers and disopyramide, but this again can be limited by AV block. Disopyramide is further limited potentially in this patient population due to renal impairment, which is common in Fabry disease. And it's important to note that patients with Fabry disease were excluded in the recent myosin inhibitor mavacamten trials, so this is not an option currently for these patients. For those who have significant symptoms related to LVOT obstruction that's refractory to these medication options, septal reduction therapy has been performed on the rare occasion with success. In terms of ventricular arrhythmias, non-sustained VT is common, but often does not require therapy, and sustained VT is rare. Compared to HCM, we don't have validated risk scores for sudden cardiac death risk stratification currently available. And of course, it's made more challenging by the fact that this is a rare condition with fewer patients to study. Patients with Fabry disease also ultimately develop issues with heart failure. This is often heart failure with preserved ejection fraction, but reduced EF can eventually occur at later stages in a similar burnt out phase. Again, caution should be used with beta blockers due to the concern of AV block. Caution also with the typical RAS inhibitors due to renal impairment, which is common in Fabry disease. There is some data supporting the use of cardiac resynchronization therapy in patients who require chronic RV pacing. And of course, with a very advanced disease, especially if it's isolated to cardiac involvement, cardiac transplantation should be considered, given the high mortality and morbidity associated with cardiac complications from Fabry disease. Just one quick slide about gene therapy, which represents a potential and promising future therapy. This is a pilot single-arm study from Alberta of 5 adult patients with classic Fabry disease who were infused with lentivirus transduced stem cells that were engineered to express the alpha-galactosidase enzyme. And from this figure, you can see that all patients actually produce the enzyme to near normal levels within 1 week. Of course, the enzyme activity did decline thereafter, but still remained above baseline levels, again, suggesting promising results. Importantly, no serious adverse events were seen. Of course, long-term studies still need to be done before this can be instituted in clinical practice. In terms of cardiac surveillance and follow-up in these patients, there's no clear evidence for this. This is all expert consensus. The more recent European statement suggested 12-lead ECG, 24-hour ECG monitoring at baseline and every 6 to 12 months. Echocardiogram at baseline with the development of new symptoms or every 1 to 2 years. Stress echo should be considered in patients with symptoms that could be suggestive of LVOT obstruction, and cardiac MRI could be considered at baseline and every 5 years for further risk stratification. So that was a very brief overview. Some of the take-home points is that Fabry disease is a rare but important and treatable phenocopy of HCM that should be considered in patients with increased left ventricular wall thickness of unclear etiology. LV hypertrophy is the most common cardiac manifestation. The typical phenotypes that are seen with hypertrophic cardiomyopathy, including the apical variant, can also be seen in Fabry disease, and so this condition should be considered. ECG and echo findings often provide the first clue to diagnosis. Alpha galactosidase level, cardiac MRI, and genetic testing can further establish a diagnosis. And common cardiac complications of Fabry cardiomyopathy include atrial fibrillation, high-grade AV block, which is again more common than the HCM population. LVOT obstruction can occur, but probably less commonly than HCM patients, ventricular arrhythmias, and ultimately heart failure. The management involves a two-pronged approach with institution of both disease-modifying therapy in the form of enzyme replacement therapy or chaperone therapy, and standard treatment for cardiac complications similar to the non-Fabry population, but with some important disease-specific considerations that we previously discussed. In terms of possible future directions, I foresee potential role for artificial intelligence-assisted strategies to identify Fabry disease earlier, additional disease-modifying therapy options, and again, possibility of gene therapy as a promising potential future treatment as well. So yeah, thank you again for your attention and happy to take any questions.
Awesome. Thank you, Dr. Yeung, for this really thorough review of Fabry disease. I'm going to take one question from the audience. So feel free to unmute yourself or put it in the chat. Otherwise, we can always come back at the end to leave time for the other speakers. If there is no questions, I just want to ask you, in your practice, in your HCM clinic, because this is a very selective population that comes to the HCM clinic, what is your approach? We've had this debate, right, this morning about genetically testing everyone, or just selectively genetically testing an LVH population. And in order to accelerate the diagnostic process for Fabry disease, what is your practice? You send everyone for genetic testing? What do you do? Can you comment on that?
Yeah, that's a really great question. I don't know if I have the right answer. I don't know if there is really a right answer. I think in the ideal world, without resource limitations, we would probably have perfect knowledge of everybody's genetic profile, right? And again, we can have easily accessible genetic testing for most patients. But in reality, in our clinical practice, our genetic testing capabilities are very limited. So ultimately, for patients who are referred to our HCM clinic, most patients already have suspicion for HCM or potential phenocopies. These are usually patients who have wall thickness in the range of at least 13 to 15 millimeters, and again, without any significant underlying other alternative cause. And in those cases, I would have to say we're starting to have a lower and lower threshold for genetic testing. Of course, we take into consideration other things such as, again, family history, whether or not it'll actually influence management with respect to first-degree relatives who may have the condition. But again, because of the potential for identifying other phenocopies such as Fabry disease, I think we do have a pretty low threshold these days. I should mention one thing that I didn't really outline in my talk are some other potential testing strategies. These days, some of the we do have industry partners who provide dried blood spot testing, which provide a pretty convenient option for testing enzyme levels. And if positive in a male patient, can be sent directly for targeted GLA testing. And for female patients, they can be sent directly for genetic testing since the enzyme levels are not reliable. So again, a lot of options. I would just say pretty lower threshold these days for genetic testing, again, because of the potential implications, including management of this very treatable disease.
Awesome. Thank you. We're going to switch gear now and talk about a little bit about the treatment of hypertrophic cardiomyopathy. So I'm going to introduce my second speaker, Dr. Andrew Crean. Dr. Crean is an Anglo-Canadian with 15 years of experience in HCM, both in Toronto and in Ottawa. He, unfortunately for us, recently moved to back to the UK in Manchester to take up a chair in rare inherited and congenital cardiac conditions. Dr. Crean's clinical and research profile is focused on hypertrophic cardiomyopathy, which is his first love, and his second love is Takotsubo cardiomyopathy. He has expertise in cardiac MR, cardiac CT, and PET imaging, and is interested in how these techniques can best be applied to patients with rare cardiac conditions. So I couldn't think of a better speaker than Dr. Crean because he, as of last year, he had one of the most patients on cardiac myosin inhibitor. So over to you, Andrew.
Thank you, Hanh. Thank you very much. Good afternoon to everybody. Good evening from the UK. Thanks for the opportunity to speak. So this is going to be just 20 minutes, really about real-world experience. I've called it the Ottawa experience. I suppose I should call it my Ottawa experience. That experience has been extended now by Hanh as well, and I'm looking forward to hearing from her and others in the audience about their experience with mavacamten. So let me see if I can make the slides move. Oh, yes. Disclosure, first of all, I'm also on the Speakers Bureau for BMS. So the HCM clinic in Ottawa is a fairly new phenomenon. It was a bit ad hoc before 2018. It was various cardiologists with various patients, but there wasn't really any sort of formal program until we put it into one place in 2018. We didn't have our myectomy service. We really weren't doing very much alcohol septal ablation, and a lot of the patients who needed advanced therapies were being sent down the road to Toronto. By the time that I left and Hanh started, we had managed to establish a more formal program. Hanh had just joined, or was just joining, just as I was leaving, and certainly at the time I left, we had about 1,000 patients under follow-up. I'm sure it's more now. We've done about 50 myectomies successfully, and we'd instituted formal HCM review meetings with HCM and surgery and anesthesia, and we were starting to experience a lot of patient and physician interest in mavacamten, and of course the patients are often involved with the HCMA, which is the American Society for Hypertrophic Cardiomyopathy, and in America they had mavacamten a year before Canada. So we got mavacamten in Canada at the start of January. Effectively, it was approved a little bit before that, but wasn't really available to us to prescribe until the beginning of January 2023. So just over a year. And we were very fortunate, really, in that BMS were very supportive, for obvious reasons, of course, but very supportive in helping us to get patients started on therapy, and actually did a fair bit of the administrative work in the first instance, which really allowed us to pick up speed quite quickly and get a number of patients on after being seen in the clinic. So between January and September last year, there were about 84 patients that were seen and considered. 12 were felt to be inappropriate for one reason or another. There were some that were under consideration. A few more of those have now gone on to mavacamten. But at the time I made these slides, there were just under 50 patients who were on therapy, and there were 8 who had started therapy but then withdrew, and we'll talk about that in a minute. So this was the pre-mavacamten baseline gradient of these patients. Now, I should emphasize these patients are mavacamten naive, but they're not treatment naive. So almost all of these patients will be on a beta blocker, and a number of them will be on disopyramide as well. And you can see that despite those treatments, there are really quite substantial gradients present either at rest or with Valsalva, or in some cases with exercise. So the way I'm not sure how familiar the audience are with mavacamten, but basically, the way we do this is we start the patients on a dose, a lowish dose, and they have the same dose for the first 3 months. And during those first 3 months, they have an echocardiogram at the end of each month, so that we can make sure that firstly, that the gradient is hopefully improving, and secondly, that we're not causing any trouble. And we'll come on to the trouble that can be caused in a moment. So in our cohort, you can see that the mean mavacamten gradient was about 120 millimeters of mercury, but by 1 month this had dropped already to a mean of only about 33, and then after that, second and third month, really not much change. So a signal here of a very early benefit, it seemed. And that certainly seemed to chime with what the patients were telling me. They would often say, you know, I knew within a week, 10 days, I felt completely different, and that's certainly what our data seemed to bear out. And this is just a graphic display to show you the pre-post gradients at different time points. So black is the pre, and then the colored bars are the gradients as time went on. The other thing that was interesting, and this has been borne out, I think, in other people's data sets, is that there was a clear signal of benefit in terms of atrial natriuretic peptides, so BNP. And you can see that in most cases there was quite a clear drop. In some cases, a very dramatic drop from start to only 3 to 6 months. In many cases, these are 3 months, actually. They're not all 6 months. So there seemed to be an early response. And when there was a response like this, it seemed to be a reliable marker, actually, of benefit. We saw similar changes with troponin, but it was less marked. So I said I would talk about patients who didn't want mavacamten, and there were a few different reasons. In some cases, they'd already gone ahead and had a myectomy and obviously felt much better. Some people felt better just on an increased dose of beta blocker. Then we had a few people who had concerns about potential side effects, given that it was a new drug, although the side effect profile is actually very favorable. We had a couple of concerns about patients who were more elderly. So I do have, I think my oldest patient is 89, but we had some patients in their 80s who really weren't sure that they wanted to be taking a new drug at that time in life, and also not sure that they really wanted to be coming back to the Heart Institute once a month for an echocardiogram for the first 3 months as well. We had one patient here whose mother was on it, and he actually wanted to see how his mother got on first before he committed to going onto the drug. In fact, she's done very well on the medication, and he has now subsequently started mavacamten with benefit also. And we also had a few patients who started but stopped. Now, that was not a huge number of patients. I think it was 7 or 8. And again, it was different reasons. The reasons that stand out in my mind, there were a couple. One of the reasons was headache, actually. So there seemed to be a couple of people with a history of migraine type headache who felt that their headaches had got worse since going on the drug. There were also a couple of patients who complained of chest pain on the drug, which is a bit surprising because chest pain is actually a very common symptom in obstructive HCM. And one would imagine that being on a drug that reduces your gradient would actually reduce the chest pain. And that's often what happens, for example, post-myectomy or post-septal ablation. But I remember one guy in particular who gave a very clear story of having developed quite significant chest pain, quite tightly correlated to the commencement of mavacamten. He was a very reliable witness, very believable, and he put up with it for a while. He put up with it for 2 or 3 weeks, in fact, maybe even a little bit longer. But in the end, asked to come off the drug because he felt sure that it was the drug that was causing it, and whether it was or whether it wasn't, certainly his symptoms ceased roughly 3 or 4 weeks after stopping. The other thing that we did see in a couple of patients were drops in ejection fraction. So this is something that it's not entirely a surprise. I mean, the mechanism of action of the drug is to reduce the cross-links between actin and myosin and to reduce the hypercontractility that we see in HCM to a level of contractility that is more normal. And in the trials, in the majority of patients, that's exactly what happened. But there was a small proportion of patients, maybe 5 or 6%, in whom the contractility was reduced excessively. And so some of those patients dropped to EFs below 50%. And in the trials, the trial protocol stipulated then that they would discontinue mavacamten at that point for at least 4 weeks until EF had recovered. And in the trials, that's exactly what happened. Function did recover. And then the patient had the option of being re-challenged with mavacamten, albeit at potentially a lower dose of drug, or choosing not to go back on the drug. And so we saw a few people with drops in EF. Mostly those were mild drops, by which I mean people dropping from, to around 50 rather than anything worse. But we had one patient that I'm going to talk about in a moment who had a more substantial drop in EF and actually was admitted with heart failure. And so this drop in EF, although it's not common, it is the main reason for concern when using this drug. And it's the reason that BMS have suggested quite strongly that patients should be imaged by echo every month for the first 3 months. And then assuming they're stable on medication at that point, usually what happens is that we then do an echocardiogram every 3 months. So this is quite an echo-intensive protocol. And depending on your healthcare system, that works to some degrees well or less well. It works not too badly in Canada, where people are paid according to what they do. It works slightly less well in the NHS, where people are usually trying to do less because they don't get paid any more for doing more. Anyhow, we can talk about that in a minute. So I wanted to give you a couple of practical case studies. This was a 73-year-old lady, a retired librarian, apical-basal HCM diagnosed 20 years ago. I'm happy to say we did do genetic testing and she doesn't have a GLA mutation, but she had been getting gradually worse over the years to the point that she was becoming breathless with a flight of stairs. She said that she really wasn't able to keep up with her husband or her friends when she was out walking. And the thing that really mattered to her was that she liked to go out dancing. And, one of the useful questions in HCM is not only to say, what are your symptoms like now, but how do your symptoms now compare to your symptoms, 5 or 6 years earlier? And she said, well, I can only dance for 3 minutes at a time. And I said, well, what did you used to be like? And she said, well, I used to be able to dance for 20 minutes without stopping. So that's a huge change. And it had occurred to her that she was stopping far too often in daily activities of life. And as a result of this, I saw her, I think, in about October 2022. So it was prior to mavacamten being available. And I suggested that she might like to think about myectomy surgery. But she was unkeen. She knew that mavacamten was on the horizon. And she said, you know what, I can live with this at the moment, but get me on that drug as soon as you have access to it. So this is what we did. And here is a chart of some of her gradients over the years. And you can see she had really quite a substantial gradient back in 2020. We put her onto some bisoprolol. It improved things marginally, but she was still very symptomatic. She came off bisoprolol because she didn't like the drug. I should perhaps at this point emphasize that most of our mavacamten patients remain on beta blockers. They do not need to stop a beta blocker to start mavacamten. So usually they're on both. But in her case, she came off bisoprolol, and then we started mavacamten in March. And you can, we started actually in February, I think. And by the beginning of March, you can see that her gradient has halved. And then over the next couple of months remains pretty stable at around the same level. And importantly, what that meant is that her self-reported quality of life went from 4 out of 10 to what she described as being 10 out of 10. And I think this is an important case for lots of reasons, but one of which is to point out that we are not trying with HCM care to reduce gradients to 0. It is usually not necessary to reduce a gradient to 0 in order to get substantial symptomatic benefit. And sometimes patients and carers can obsess over the number that we report at echo, when what really matters is the symptoms that they're living with. So she had a dramatic improvement in quality of life. Yes, she has a residual gradient. Do we chase that by increasing the mavacamten? Well, in my opinion, we don't, and we'll see what other panel members think. But generally speaking, what we're after here is an improvement in symptoms, not a total improvement necessarily in the gradient. So that's a success story. So I have to balance that with a cautionary tale. So here is a cautionary tale of a 77-year-old who had a mild gradient at rest, but a Valsalva gradient of 90 odd, and lots of other problems, obesity, hypertension, diabetes, etc. And she'd been referred in, and one of the reasons she'd been referred in, apart from symptoms, was that she was due to have knee surgery, and there was obviously some concern from anesthesia about her degree of provocable obstruction. She was already taking a calcium channel antagonist, and for reasons that I don't recall, she was not very keen on trying disopyramide. But she was prepared to try mavacamten. So we started that at 5 milligrams, which was our usual starting dose. And after a month, firstly, her ejection fraction was fine. She hadn't dropped too much. She had a bit of caudal SAM, but she didn't have a Valsalva gradient anymore, and she just had mild mitral regurgitation. And she was starting to feel a change in her symptoms and improvement. 2 months later, same again, systolic function is still normal. She doesn't have any caudal SAM anymore, and she certainly doesn't have any leaflet SAM. And so, rather blithely, I said to her, yeah, you're fine. Stay on the drug, go ahead, have your knee replacement. I'm sure everything is going to be fine. Fatal last words, because on post-op day 1, she becomes acutely breathless. She's got symptoms and radiographic changes of pulmonary edema, and she's had a spike in her NT-proBNP. Now, the operation was done at another hospital, and so I wasn't made aware of this immediately, though eventually somebody from the team did let me know that she'd been admitted, and I'd looked at the imaging, thought, well, this does look like pulmonary edema. I'm worried that there's been a mavacamten effect on the ventricle. I'm worried we've dropped the EF too much, and there have been just a handful of reports of Takotsubo as well on this drug, and so I said, please, will you get an echo? And we'll decide what to do after that. If the echo is normal, we don't need to stop the drug. But if the echo is abnormal, then clearly we do. So the echo is done, and I'm fed back with information. It seems to be okay. EF is 56. It's not consistent with Takotsubo. There's no outflow tract obstruction, and there isn't much change really in the mitral regurgitation. And so they leave her on the mavacamten, they dry her out, and send her home a few days later. And we repeat the echo at the Heart Institute 1 week later. So this is the echo from the Heart Institute, and I was a bit horrified when I saw this, because this is not a normal echocardiogram. You can see the anterior wall contracts normally, but the inferior wall is echo bright, and it's akinetic, effectively akinetic, and the EF is significantly down. There isn't any SAM or LVOTO, but this is not what her ventricle looked like prior to starting mavacamten. And when I looked back, when I managed to get hold of the old echo from the hospital where she'd been having her operation, it looked not that dissimilar to this. So one of the lessons I took from this is that if you're going to prescribe mavacamten and follow these patients, you probably have to look at the echoes yourself to be sure that nothing untoward is happening. Could I ask people just to turn their mics off at the moment, if yours is not turned off? Thank you. So a week later, we repeated the echo. Wall motion abnormality was improving. It wasn't quite normal, but her EF had improved from 35 to 54. And a month after that, although the strain was abnormal, as it often is in HCM, her ejection fraction had returned to more than 55%. And she was restarted on a lower dose of mavacamten at that point, and has remained with normal ventricular function since that time. So that was a case of all's well that ends well. And it's the only case I have that I have seen so far where there has been such a significant drop in EF that there were symptoms of heart failure. So I just want to finish by letting the patients really speak for themselves. So there's no doubt that the majority of patients felt better than they did before treatment with mavacamten. And this is despite having been on beta blockers and in many cases disopyramide. And these were the sorts of things that they said. I always would ask them, can you tell me in your own words, how do you feel now? Much better, felt better right away. I would have said yes to surgery before, not now. Really helps a lot. So this is a sort of a common experience. It's not everybody, but when you ask patients on disopyramide whether they feel better, I would say maybe 40% feel definitely better. 40% equivocate and 20% no, I don't think so. With mavacamten, I would have said that something like 70 to 80% were really quite definite that they had noticed a significant difference. And it was also notable that the drug was actually much better tolerated than disopyramide. Disopyramide comes with anticholinergic side effects of dry eyes, dry mouth, constipation, very occasionally urinary retention. Mavacamten really, apart from those few patients who had either migraine or chest pain, and I emphasize I don't know whether it was the drug that was actually causing those symptoms or whether it was just chance, but apart from those symptoms, nobody really had anything. So there were really very few complaints from patients about side effects. And then the other thing was not just that they felt better, but that they were able to do more. They could do more yard work. They could go up and down stairs with baskets of laundry. They could walk and garden without getting breathless. My favorite patient can now dance again for at least 20 minutes without having to stop. For a rest. So it really does seem to be making a difference to a reasonably high proportion of patients. Clearly not to everybody, but a reasonably high proportion. So I wanted to stop, but I just conclude by saying that it was my finding that mavacamten was popular with patients, generally speaking, and certainly was discontinued less frequently than disopyramide in my practice. Many patients noticed an early benefit within a week or two. There were a few patients who had to have dose reductions due to a drop in EF. One patient was hospitalized, as we said. The gradients improved in most people, but much more importantly, the vast majority of people reported a clearly better quality of life than they had had before. And this ties in with some of the trials, the VALOR trial, for example, which looked at patients who were potentially eligible for septal reduction therapy with alcohol or with surgery, and found that the vast majority actually decided that they didn't want those things once they were on mavacamten because their quality of life improved so much. The one thing I would say is that it's demanding on the echo lab, and you need an agreeable echo lab to help you schedule things appropriately. And just keeping track of where people are in their echo schedule is a bit of a challenge, and you need some administrative support to help with that. So at that point, I think I should stop and open for questions, and I'd be very keen to hear from the audience and the other panel members what their experience has been with mavacamten as well. Thank you.
Thank you, Dr. Crean. That was really nice to hear your experience on mavacamten. Feel free to unmute yourself or write your question in the chat. In the meantime, I would like to play a little bit of a devil's advocate and
excellent.
And ask you, what is your practice regarding, this medication has, good long-term extension. It looks like the results are good as well. So not a whole lot of change in the long-term follow-ups. But so, how do you approach your patients in terms of how do you offer them the option of mavacamten versus myectomy, for example, for younger patients, right? Because we know that myectomy is still the
gold standard.
The gold standard. It is the lowest mortality of all the surgeries, if done in a center of excellence. So, with that regards, what has been your approach?
Yeah, that's interesting. So I don't have an approach yet in England because my first mavacamten clinic is next Wednesday. We've only just got approval to start using it. So, I think my approach is probably going to be a bit different here than it was in Ottawa. In Ottawa, we were lucky enough to be able to establish a half decent myectomy service with a committed surgeon, and so that and also had Toronto down the road, and so we had lots of surgical opportunity. We don't have a really a surgical service where I am currently. I'm hoping we can change that over time, but for now we don't. So in answer to your question, I think it depends a little bit on the patient's situation in life. So if it's a patient in their 60s or so, first of all, I give everybody the option. I say, look, this is the pathway. You've got a condition that isn't going to get better by itself. We can relieve it once and for all with an operation, albeit with a very slight surgical risk, or you can If you don't like the sound of that, you can temporize for a while on this drug. We know this drug works well short term. We don't know much more than a year at the moment. And if it doesn't work for you, we can still always consider surgery. What I actually used to do was to send them to talk to Mark Ruel at the same time as prescribing mavacamten in many cases, certainly for the more severe ones. So that they were in both pathways, if you like. And I would say to Mark, this isn't a referral for surgery. This is a referral for a discussion about surgery, and so that you know them. And if I ever sent him a patient towards the end of 2022 for surgery, he wouldn't accept them. He'd say to the patient, I want you to try mavacamten first. And if it doesn't work for you, then we'll think again. There is an argument, I think, for young, highly active patients to have a one and done operation. And be sort of fixed, basically. Once you've had a myectomy, your obstruction shouldn't recur. It's very rare for obstruction to recur post good myectomy. And so I think for young, highly active people who want to play a lot of sport, I mean, the whole sport thing is another talk entirely, isn't it? But there are lots of people who do want to play sport, whether we advise it or not. And maybe for that population, myectomy is still the gold standard. But as you qualified yourself, it has to be a center with an experienced surgeon with good results. And unfortunately, around the world, and particularly in Europe, that is still less common than it is in North America.
Yeah, thanks for that. I do like the comment on sometimes it can be a temporary measure. It doesn't have to be black or white. And I do find that there's a lot of patients who have been obstructing their entire lives and don't know what not having symptoms mean.
Right.
So in that case, I find that mavacamten can, if they feel much better, then they can decide whether to stay on it or do surgery.
Right. I always like it when they've been on it for a few months and they say, my asthma is much better.
Right. That's right.
Have you had much chance, Hanh, to use mavacamten? What has your experience been?
I've studied it on a few, and the few that I studied it on was older patients with 10 reasons to have shortness of breath, and I'm not sure that they felt better on it, but their gradients have certainly decreased without a drop in EF. So definite drop in gradient for sure.
Okay, great.
A last question from Darwin. A possible question is, if you need another one, will you start offering mavacamten as a first choice before calcium channel blocker or beta blockers?
That's an interesting question. I think that in 5 years we'll be doing that. Mm-hmm. I'm not doing that at the moment. So I tend not to use calcium channel blockers. It's purely historical. I grew up using beta blockers and HCM. So I always start with a beta blocker unless there's a good reason not to use one. I would, however, now, and my practice has been to abandon disopyramide and just go straight to mavacamten as second line. And that's partly because historically disopyramide has gone through phases of being unavailable in Canada or very difficult to obtain. And partly because just so many of them don't like the side effects, whereas I found mavacamten to be very well tolerated, as I said, except for those few couples of examples, which may not be mavacamten side effects, but I think in 5 years, people will be using mavacamten first line, even before beta blockers or anything else.
What is your practice, Darwin? Do you sometimes skip the beta blocker and calcium channel blocker?
I think everything that Dr. Crean has mentioned, I think is very similar to our experiences here. I think it's very well tolerated. There's very significant improvement in symptoms. I've only encountered one patient who has had a drop in EF, and I think that speaks to, again, the algorithm that tries to find the lowest effective dose. I also agree that I prefer mavacamten these days over disopyramide, but I would, of course, in current guidelines, still suggest starting with beta blockers first. Again, beta blockers I prefer over calcium channel blockers for similar reasons. And then beyond that, then I would consider mavacamten. So very similar practice at this point.
Very similar, yeah. Darwin, have you seen the same thing with BMP? Have you been tracking that at all?
You know what? I regret not checking those as frequently. I probably should have prior to starting. That would have been really interesting. But yeah. I have seen some instances where we do have that available. But again, we haven't consistently been tracking it as much. But it's very interesting to see your results, and I'm not surprised.
Yeah. One of the other interesting things that's starting to come out, I think there was an MR sub-study of the Explorer trial, which suggested, or at least suggested, there was a signal of improvement in LV mass in these patients. And firstly, I don't know whether I believe it yet. Secondly, I don't know whether that's because of afterload reduction or whether the drug is doing something else at a molecular level that's actually causing LVH regression. But I mean, that's going to be really interesting, I think, as we go forward to watch that.
Yeah, I think we have lots to learn with myosin inhibitors. So very exciting area. Thank you so much for your talk.
Thank you.
Now, last but not least, we're going to be talking a little bit about risk stratification with Dr. Bethlehem Mengesha. Dr. Mengesha is a cardiac imaging and research fellow at the University of Ottawa Heart Institute. She graduated from Jimma University, a medical school in Ethiopia, then completed her internal medicine and cardiology training in Shamir Medical Center in Israel. Her main research and clinical interest projects during her current fellowship focuses on the role of multimodality imaging in cardiomyopathy and structural heart disease. Over to you, Betty.
Okay, thank you very much for the introduction. Do you see my screen well?
Yeah.
Okay, great. So I'll be presenting on the role of imaging in risk stratification of patients with hypertrophic cardiomyopathy. I have no disclosures. So the three pillars of hypertrophic cardiomyopathy management, as you all know, focuses on symptom control, sudden cardiac death prevention, and genetic testing to identify family members that may have the condition. So the sudden cardiac death prevention will be the focus of this presentation. I will start with a short case, which will be followed by a question for the audience. I have not arranged a poll, but the answers will be revealed during or at the end of this presentation. So this is a 50-year-old female patient with non-obstructive hypertrophic cardiomyopathy. She presented after she experienced syncope while she was at the beach. She skipped breakfast that morning and napped on the beach for a while. She had a syncopal episode when she stood up abruptly. Her ECG and subsequent Holter were unremarkable for arrhythmia. Both echo and CMR showed asymmetric hypertrophy with LV ejection fraction of 50%. There was systolic anterior motion of the anterior mitral leaflet with LVOT obstruction. In addition, LG images on cardiac MR showed large scar burden. Her family history is notable for a paternal uncle who died of unknown cause at a young age. So the question here is, according to the most recent American guideline, whether this patient has indication for ICD as a primary prevention. Option A is yes, it should be considered, and option B is no. Patient has low risk. So I'll leave you to think for a few seconds, but I'll have to move on for time's sake. Okay, so if we look at the prior 2011 American guideline, it identifies family history of sudden cardiac death, unexplained syncope, non-sustained VT, and massive LVH as a class 1 indication. Abnormal blood pressure response to exercise was a class 2A, and LVOT obstruction and genetic mutation were 2B. This has now changed and has been replaced by newer risk markers, including the presence of apical aneurysm, systolic dysfunction, and large scar burden, which have been associated with increased risk of future life-threatening ventricular arrhythmias. The 2020 American guideline recommendation on primary prevention now incorporated these newer risk markers, but note that both large scar burden on cardiac MRI and non-sustained VT are both 2B indications. The patient I presented seemed to have had LVOT obstruction associated syncope in the context of dehydration. Therefore, she does not get a point for unexplained syncope. But she does have a class 2A indication for family history of sudden cardiac death. And also her LV ejection fraction is borderline reduced, which is concerning. And she also has a large scar burden. So given these findings, the patient was told that she would benefit from an ICD, and it was recommended. But now patient comes back concerned because her distant cousin, who also happens to be a cardiologist in Italy, tells her that she's at low risk and does not need ICD implantation. So let's see how that came about. The 2014 EAC guideline, like the American guideline, is composed of clinical and imaging risk markers. Interestingly, the European model includes predictors such as age, left atrial diameter, or LVOT gradient, which are not included in the American model. In the European model, the predictors are not used individually. Instead, they are fed into a risk calculator, which then gives us an estimate of the 5-year risk of sudden cardiac death. If the calculated risk is less than 4%, that's a low risk. They don't need an ICD. But when the 5-year risk is 4 to 6%, that will be considered intermediate risk, and there is a 2B indication. But when the risk score is more than 6%, it's considered high risk, and ICD should be considered. So when we calculate the risk for this patient I presented, her 5-year risk of sudden cardiac death is about 3.2%, which makes her a low risk, according to this, and explains why the patient was concerned and confused. So if we see how the AC model was developed, so it's a prognostic model that's based on a mathematical model, which is applied as an individualized risk calculator per patient. It was derived from a retrospective multi-center longitudinal study done by Oman and colleagues of 8 pre-specified predictors. All the ones listed on the left here were associated with higher risk of sudden cardiac death and appropriate ICD shock, with some being strong predictors than others. And they were weighted accordingly on the risk calculator. So this was then validated internally and externally, and later adopted by the 2014 AC guideline. While there are commonalities between the two guidelines, we need to pay attention to how each predictors are defined in each. So for example, family history of sudden cardiac death in the American guideline refers to a 1st-degree relative, as well as 2nd-degree or multiple 3rd-degree relative that had sudden cardiac death at a younger age. Whereas the European guideline limits this predictor to only 1st-degree relatives, which may explain why we had discrepancy in risk estimation for the patient I presented. Unexplained syncope is pretty much defined the same. Both guidelines stress the need to exclude other causes of syncope, such as vasovagal or orthostatic. But also, we need to exclude LVOT obstruction-associated syncope. And therefore, a thorough history taking is needed to make these distinctions. Documented non-sustained VT receives different weight in each guideline. The threshold is lower with the European guideline, where the arrhythmia does not have to be very rapid or frequent. They even mentioned that there is no evidence that the frequency or the rate determines high risk of sudden cardiac death. Whereas the American guideline, they restrict this to a more frequent, prolonged and faster arrhythmia. Even then, it receives a class 2 indication. Okay, so let's move on to maximal wall thickness. Massive LV hypertrophy, which is defined as wall thickness measuring more than 30 millimeter or more, is a major independent risk predictor. And this was shown on this study by Spirito and colleagues. As shown on the graph, the risk of sudden cardiac death increases progressively and in direct relation to wall thickness, with those having massive wall thickness measuring 30 millimeter and above being at the highest risk. But it's important to note that this is a continuum, and those with wall thickness of 25 to 29 millimeter are also at a higher risk. And as imagers, we should be careful on how we measure the wall thickness. The image on the left is to show common errors made in measurement. We need to be careful not to include RV structures when we're measuring the wall thickness at the septum. And also, proper image prescription is important. So if the short axis image are prescribed diagonally instead of perpendicular to the long axis of the LV, then we can potentially overestimate the wall thickness. Apical aneurysms are commonly seen in the apical HCM variant, and it can be a source of ventricular arrhythmia and thromboembolism. The 2017 publication by Rowan and colleagues is what put apical aneurysm on the map as an independent risk predictor. The main takeaway point from this study is the event rate for patients with apical aneurysm was quite high, approaching almost 5% per year. Compared to HCM without aneurysm, seen on red as on the graph, those with aneurysm, the blue graph, had almost 5-fold higher rate of arrhythmic events and higher overall adverse outcome. Also, there was no relation between aneurysm size and outcome endpoints. Another important point to make from this study that apical aneurysms were missed in 46% of cases when echo was used without contrast, and they were identified using cardiac MRI. So this highlights the importance of using cardiac MRI or echo with contrast to identify apical aneurysms. Regarding scar burden quantification, the LG images are acquired in different views, including ACO stack, short axis stacks, where the LV is segmented from the base to the apex. To quantify the enhanced myocardium, different techniques have been used, one of them being signal threshold versus reference mean, where we select an area of normal myocardium as a reference, and we set a grayscale threshold by applying a number of standard deviations above the mean signal intensity of the normal myocardium. Then the semi-automated algorithm, it identifies the high signal intensity LG pixels in the LV wall, and we quantify that as scar burden reported as a proportion of the total LV mass. There are other techniques such as full width half maximum, and some experts even prefer to manually adjusting grayscale threshold to visually define the late guide enhancement. So although studies have shown accuracy and reproducibility of these techniques in real life, we see a lot of room for subjectivity. It may be difficult. Chan and colleagues have shown extensive LGE, especially a scar burden of more than 15% of the LV mass, to be associated with a 2-fold increase in sudden cardiac death event rate in those patients who otherwise were considered to be at low risk. Another important paper is by Mentias and colleagues. It's the first paper to extend the importance of LG findings into both obstructive and non-obstructive subgroups. And it has showed that LG burden of more than 15% to be associated with higher rate of sudden cardiac death and appropriate ICD shock in all the subgroups. So both LV mass, wall thickness, and LGE are not constant and may change with time. The rate of progression may be different in each individual. The wall thickness may even regress with LG progression. Some studies have shown among factors like age, baseline LV mass, genetic mutation, or wall thickness, LGE mass at baseline was only found to be the predictor of LG progression. The American guideline recommends baseline imaging assessment with echo, although in tertiary centers, most experts prefer to have a baseline cardiac MRI as well. Follow-up and risk assessment is done in a year or 2 years basis. According to the guideline, it does not recommend the frequency of timeline for imaging with cardiac MRI. Instead, it recommends cardiac MR to be used as a tiebreaker if the standard risk stratifications are inconclusive and decision for ICD remains uncertain. So in such cases, cardiac MRI can be helpful in identifying apical aneurysms or assessing LV wall thickness and extent of fibrosis. The performance of the American risk factor strategy and the EAC risk score were compared in several studies. And overall performance did not differ significantly, but there were differences. So the EAC risk calculator has been criticized to be a rigid mathematical model with low sensitivity, theoretically leaving many patients unprotected without ICD, and potentially with poor flexibility to evolve as new evidence emerges. The enhanced American algorithm, on the other hand, demonstrated high sensitivity in identifying high-risk patients, but its ability to identify low-risk patients is not high, potentially leading to an excessive device implantation rate. So in practice, we see that most experts adopt both the European and the American risk stratification approach. in primary prevention. The 2022 AAC guideline on ventricular arrhythmia, it tries to find a middle ground between these two guidelines by suggesting a hybrid approach. For example, for those that are at intermediate risk according to the European guideline, by adding the newer predictors such as apical aneurysm or reduced LV ejection fraction or extensive enhancement. By using these points, we can probably recommend it as a class 2A. So both American and European approach facilitates discussion with the patient and shared decision-making by providing an estimate of the absolute risk. In patients with discrepant risk stratification, when there are uncertainties, this should be clearly explained to the patient, and shared decision-making should be encouraged. But this is not to absolve the physician from decision-making. We should still give our recommendation to the base of our clinical judgment and knowledge, but also we need to take into account patients' needs and preferences. So we also need to know when to refer patients to an HCM expert clinic, which is listed here. So the next case is a 40-year-old male who presents with exertional dyspnea. He doesn't have a family history of sudden cardiac death. His echo demonstrates apical variant hypertrophic cardiomyopathy with no significant mid-ventricular gradient. On MR, we see preserved function. He also happens to have a small apical aneurysm and a large scar burden. Patient refused to have genetic testing. Now the question is, which of the following is true regarding risk stratification of apical HCM? So option A says the rate of sudden cardiac death is similar or comparable to the other variants. Option B, current risk stratification algorithm cannot be used to estimate sudden cardiac death in this variant. Option C, the cardiovascular mortality is more common in women than men. So I'll give you a few seconds to think. Okay, so patients with apical HCM are usually younger at presentation compared to the other variants, and they are more commonly seen in men. They may or may not be associated with apical aneurysm or mid-cavitary obstruction. On the right, we have an example of echo images of a patient with apical HCM with a small discrete apical aneurysm as shown in the apical three-chamber view. There is a corresponding polar plot showing loss of longitudinal strain apically. In the bottom, we see Doppler traces from a patient with apical HCM and mid-cavitary obstruction. And we see a mid-systolic signal loss or dropout due to cavity obliteration, followed by an early diastolic tracing from paradoxical jet flow of trapped blood coming out of the aneurysm after the neck has relaxed during diastole. In some studies, they have shown high prevalence of mid-cavitary obstruction among patients with apical aneurysm, but they haven't been shown to be an independent risk predictor for sudden cardiac death. On the left is image of stress cardiac MR with quantitative perfusion mapping of a patient with apical HCM. And the images show stress-induced perfusion defect in the hypertrophied apex with corresponding reduction in stress myocardial blood flow and the reduced myocardial perfusion reserve, indicating microvascular disease in the hypertrophied apex. Perfusion imaging is being studied for its potential in risk prediction in this group. So there are not a lot of studies looking at the long-term outcome of apical variant. Among the studies that looked at a fairly larger population of apical HCM is one that's done by Erickson and colleagues, and where they follow patients for around 25 years. And they came to the conclusion that they have patients with apical HCM have benign outcome in terms of cardiovascular mortality. Other publications that came out after that by Nguyen and colleagues and Claridge, they concluded otherwise, in that the variants, the apical variant, are also at higher risk for cardiovascular mortality. But if we look at all three studies, the event rate for sudden cardiac death is relatively low, but there's increased cardiovascular mortality in the latter studies. which was actually driven by heart failure and stroke-related mortality. Worse outcome was also seen in women than men. And we can argue some of the standard risk predictors used may not necessarily apply in the apical variant, for example, aortic obstruction, or even family history of sudden cardiac death, since only 1/3 of this variant have genetic mutation positive. But there are currently no trials or predictive models to guide ICD insertion specifically for apical HCM. And in practice, we do use the standard AHA risk predictors and EAC model as we would for the other variants. Last question would be, let's say the previous patient had a brother who is a professional athlete. He underwent screening and was found to be genotype positive and phenotype negative. Now the question is whether he should continue to participate in competitive sports. Option A says yes, he's not at increased risk for sudden cardiac death. Option B, no, the fact that he has a family history and he's gene positive puts him at higher risk. So I'll let you think for a few seconds. Which one you think is correct? Okay, so several large observational studies in recent years have shown that it's probably safer for patients with HCM to be engaged with exercise, including vigorous exercise. Live HCM trial presented last year at the ACC by Dr. Lampert and colleagues. They've showed that individuals with HCM, including those who are genotype positive and phenotype negative, who are exercising vigorously, do not experience a higher rate of death or life-threatening arrhythmias than those exercising moderately or less. Another study by an Ontario group has shown that most of the sudden death or arrhythmic events in HCM are not even related to physical activity. Instead, they occur when they are at rest. So the guidelines give recommendations based on patient's baseline risk of sudden cardiac death, presence of or absence of exercise-induced arrhythmia, LVOT gradient, and blood pressure response to exercise. For genotype positive and phenotype negative patients, such as the previous case, the European guidelines used to have a more conservative in terms of competitive sports, but on a more recent guideline, they give a 2A recommendation, similarly to the American guidelines. So if HCM patients are interested in engaging in a moderate to high intensity activities, it's best to refer patients to an HCM expert center. And also this has to be a shared discussion with the patients. This is the last slide showing the global trends throughout different continents before and after the year of 2010, where you can see the global trend of sudden cardiac death gradually dropping, especially after the year 2010. On the right, we see the rate of HCM-related mortality in the US, also gradually dropping throughout the years, and the rate becoming comparable to the risk of the general population. So this is to show that we are on the right path. And since it's an evolving field, we may further improve our risk stratification methods in the future. Well, these are the answers for the questions presented, and we can discuss about them. We can also discuss if we have additional questions. My take-home message would be risk stratification for sudden cardiac death is an important pillar of HCM management, and we should make a comprehensive systematic assessment by integrating both guidelines and also multimodality imaging. While some patients can be followed by general cardiologists, we need to know when to refer to HCM expert clinics, as I've outlined before in the prior slides. And thank you for listening.
Thank you for the great talk, Betty. I'm going to open it up to the audience if they have any question. I was wondering if after 15%, let's say they have no other high risk features for an ICD, is there any increased risk if the more LGE there is, let's say 30% or 50%, I guess it is, but is there any data on that?
Yes, the more LG there is, there is data showing that there are more risk not only for sudden cardiac death and arrhythmias, but also for developing end stage or burnt out HCM. In other words, systolic dysfunction. The problem that I think the reason that it's not a 2A indication, like a stronger indication on its own, is because there has been inconsistent data. There is a meta-analysis including thousands of patients and other studies that some of them have showed its risk prediction in terms of sudden cardiac death, but when it's adjusted for ejection fraction, then it doesn't become significant anymore, or some of them did not even show significance. So there are some inconsistencies in the data, although there are several other studies proving that it is a strong predictor. So I think that's why it's left as as a 2B indication.
Mm-hmm. Awesome. I'm going to invite the rest of the panel, the speakers, to open up their camera. Oh, I have another comment. Sudden cardiac death risk is thought to be lower in patients, in patients more than 60 years old, but there's some suggestion that increase in cardiac risk from apical aneurysm is age independent. So the question is, what has been your approach to patients over 60 with apical aneurysm?
Well, it's interesting because I actually had the same question for the experts. I'm an imaging fellow, and I've also come across literature that the risk for elderly patients is much less. Their event rate is much less. And I was also wondering the same. We wanted to ask you how you risk stratify elderlies, because we are now diagnosing more and more patients, even in the 70s or even in their 80s with HCM.
Shall I take that?
Sure.
So over the years, first of all, great talk, Betty. I really enjoyed it. I thought you tackled a number of the difficult areas, and you had some great case examples to try and make your point. So thank you. I've learned to treat apical aneurysms with more respect than I did when I was a younger physician. You only have to have a few patients die before it doesn't really matter what the evidence shows. You're scarred for life. So I can recall a patient who had apical HCM and a small aneurysm, really quite small. And you've already made the point that size actually probably doesn't really matter in terms of risk from aneurysm. But he really just had a very small amount of enhancement at the apex. And this patient, who was over the age of 60, was found collapsed at his home and unfortunately couldn't be resuscitated. And it has made me a bit more nervous about apical patients because, as you point out, I think 15 years ago we all said, oh, apical is benign. It's a benign form of HCM, and I think increasingly, as you suggest, we realise that it probably isn't. So, in answer to your question, what do I do with apical HCM? I screen them more carefully. So mine have an MRI every 2 years for that reason.